Hello and welcome to the CMHC podcast series entitled Updates and Expert Perspective in the Management of Chronic Kidney Disease in Patients with Type 2 Diabetes. Welcome to this podcast number 5, where we're going to discuss new emerging therapies and approaches with I hope by now have become good friends, Dr. Rajiv Agarwal and Catherine Tuttle. And we're going to get into the mix here because we're now going to be talking about GLP-1 RAs. And these boys have not made the pillars yet because we're waiting to see what's going to happen with renal outcome in the FLOW trial. And Kathy, I'm going to dive right in, and I want you, this is your forum here, these are your boys. Tell us about the GLP-1 RAs and the FLOW trial that we're all involved in.
Well, sure. Let me start with a little bit of context once again. The kidney protective properties of GLP-1 RAs were first observed in the cardiovascular outcome trials, very similar to what we saw with SGLT2 inhibitors. And with these agents, of course, the trials were originally designed to prove cardiovascular safety, but like the SGLT2s, they went far beyond safety to efficacy for reducing atherosclerotic CVD events. So nice contradistinction to the SGLT2s, which are mainly heart failure drugs. And also from the perspective of cardiovascular risk, makes them a very attractive potential combination therapy. And they work quite differently, we think. The kidney disease outcomes were secondary outcomes in those trials as they were for the other CVOTs and SGLT2 inhibitors. And what we see across those trials is that these agents reduce albuminuria, and particularly the long-acting agents also show evidence of slowing GFR decline. In addition to the CV outcome trials, there was another trial called Award 7 that was a glycemic control study as the primary outcome in people with stage 3 and 4 CKD who had a baseline eGFR of 35, so the lowest GFR of any of the GLP-1 clinical trials. And even though glycemic measures were the primary outcome, we saw really a striking effect on albuminuria reduction and slowing of GFR decline, even in people with very low GFR. So they had people down to a GFR of 15, and even in the stage 4 CKD group, so that would be GFR of 15 to 29, we saw this effect. And then in a exploratory but pre-specified analysis showed that the rate of what we would consider outcomes for a kidney disease trial, so 40% GFR decline or kidney failure, dialysis or transplant, was reduced by more than 50%. So all of those observations led to the design of the FLOW trial, which is the first dedicated kidney disease outcomes trial in people with type 2 diabetes and CKD. And the entry criteria are very similar to the SGLT2 of the finerenone trials. I'll just leave it at that. They do have albuminuria, and most, but not all, will have some measure of GFR impairment. And then they're randomized to semaglutide or placebo on top of an ACE or an ARB. SGLT2 inhibitor use is allowed, and I believe it's at about 15%, so substantial number, but still relatively low use, and there are about 3,400 patients. And this trial is expected to report out in about 2 years, 2024. So that'll be the main outcomes trial. There's a companion trial called REMODEL, which is a smaller trial of just over 100 patients. It's not fully enrolled, trying to unravel the mechanisms for this. We think based on preclinical models, it's likely to be mostly the anti-inflammatory effect, again, at the kidney level, would complement SGLT2 because of different mechanisms. But this study is a similar design, except people will have MRIs and kidney biopsies to analyze the histology, and also deep phenotyping with omics to look at the molecular pathways that, one, are active at the time of enrollment, and then after 1 year of treatment. And we'll have comparisons to placebo. So we'll not only see the drug effect, but also even the placebo group will be very interesting to see what happens over time at the tissue level. And then a number of biomarkers that map to molecular pathways.
So that's very good, Kathy. Now, Rajiv, in the fidelity analyses, we did a number of analyses on with SGLT2s, and then we did have people on GLP-1 RAs. There was no shortage of that. So did we see anything significant there in terms of additivity or synergy or anything?
We found that the cardiovascular and kidney protection existed with and without the use of these drugs. But remember, these are all post-hoc analyses. They are not powered to look at the outcomes because they have very few patients. Nonetheless, the best evidence for this comes from the reduction in albuminuria, because that's happening even in people who are on baseline SGLT2 inhibitors with finerenone. So it appears as if the drugs are working together nicely, and especially the post-hoc analyses that we have now, which show that there's less hyperkalemia potential when you use the two drugs in combination. It seems like we can have at least the three pillars here, the ACE-ARB as a backbone, like Kathy pointed out, SGLT2 inhibitors and finerenone, because they seem to be playing well together, at least in this 13,026 patient analysis that we call fidelity. Same thing with the GLP-1 RAs. We didn't find any effect modification because of the GLP-1 RAs. But like to emphasize what Kathy pointed out, is that GLP-1 RAs seem to be much more anti-atherosclerotic and reduce the incidence of myocardial infarctions compared to SGLT2 inhibitors of finerenone. So, finerenone and SGLT2 inhibitors, they play well with cardiovascular death and heart failure hospitalizations. But the GLP-1 RAs, they seem to have an anti-atherosclerotic effect, which is pretty nice. There's a nice meta-analysis by Dr. Sutter in Lancet, which shows an 11% relative risk reduction for myocardial infarctions with these drugs. So I think that this is very important, and especially in the people, I live in a state which has a lot of obesity. The weight loss that the patients have puts a smile on these patients' faces. I have many people who come in and says, "Doc, I've been taking this drug and I have lost 20 pounds, 25 pounds." And that's a big motivator for them to continue, even though they might have slight amount of nausea and early satiety, and they might not be able to eat as much as they were, but they seem to be more satisfied than what they were before. And I think that's a big motivator for patients. On an extension of this is the combination incretin therapy, the G1, GIP, GLP-1 RA, tirzepatide, and I just read the results of it last Thursday in New England Journal of Medicine, and a third of the patients have 25% reduction in body weight or more. It's just mind-boggling. Is that how can a drug produce an effect which is even trumping bariatric surgery? I mean, it's really a remarkable drug. And I think that the combination of these treatments is going to definitely change the landscape of both the cardiovascular, atherosclerotic disease, heart failure, obesity. I think that the people, once they have access to these drugs, they will actually feel a lot better about their condition. Of course, diabetes and kidney disease is a terrible disease, but I think these therapies are truly game changers, and we're seeing the changing of the landscape in our lifetime year by year, which is really remarkable.
So let's kind of round this up, because there are a number of ongoing trials with finerenone in heart failure, in non-diabetic kidney disease. And so why don't you give us a quick overview of those, Rajiv?
Yes, so we have the FIND CKD. The FIND CKD is looking at the slopes of GFR, And these are non-diabetic patients, several thousand patients there, and they all have albuminuria, very high albuminuria or moderate albuminuria, A2 or A3, but we are looking at the slopes from baseline to several years out. We have a very important trial called Fine Arts, which is looking at heart failure with preserved ejection fraction, which is not something that we have many treatments for. SGLT2 inhibitors were just shown to be effective, but Fine Arts is looking at finerenone. The unique thing about this trial is they are using a 40 milligrams dose of finerenone. The top dose that we are using right now is 20 milligrams, whereas this trial is using 40 milligrams of finerenone. We talked about the confidence trial. There are some large real-world studies that are being designed. There is a trial that they did in diabetic retinopathy. There's a pediatric trial. There are some real-world evidence studies that are going on in Europe. So there's a lot of interest. But, I think that no matter what trials we do, the patients can't get to this medicine and you can't prescribe it to them. I think these trials are not worth it. We have to figure out a way by which we can get more people on these therapies, because we don't want to wait till the patents run out before the patients get this medicine. It would be just a shame in the years of lives lost. We have to work together to get access to these medications.
So that is a topic for another time, and a very important topic because that is ultimately the final common pathway that is limiting. So with that, I want to thank both of our participants, Drs. Agarwal and Drs. Tuttle, for joining us and doing this series of podcasts and helping us understand this topic. There are new data coming out. There is an EMPA kidney study. We're not ready for prime time yet because it hasn't been announced yet, but that will be available soon. We'll be talking about that and other topics that are not ready yet to come out of the oven. But we will share with you this information when we have it and hopefully improve your practice and extend it. And so with that, on behalf of my colleagues, Drs. Agarwal and Tuttle, thank you very much for joining us. And hopefully you enjoyed this.
Thank you.
Thank you, George.